Hey everyone, my name is Adam Berry, and I'm going to be presenting on eating disorders this week, specifically anorexia, and in the context of the documentary Thin. So first I'll say it's a documentary and it followed several patients in an inpatient treatment center for eating disorders. So I guess if there was a central character, it would be Shelley. Shelley is who I'll be presenting on today. I would say the majority of the documentary followed her story, although I could have done this presentation on several different people. But for demographic information, Shelley is 25. She is a cisgendered woman. She's white. As far as we know, she's single. She doesn't wear a ring or mention a husband at any point in the documentary. She referred herself. She's in Renfrew, the Renfrew Center, which is an inpatient treatment center for eating disorders. Her presenting complaints, she weighs 84.3 pounds when she arrives to Renfrew. And she eats exclusively through a feeding tube that she had inserted in her stomach 5 years ago. Beyond that, she is dealing with feelings of depression, anxiety, worthlessness, and she has some issues with substance misuse as well. Behavioral observation. She appears appropriately dressed for the treatment center. She appears clean and well groomed. She makes appropriate eye contact. She looks at the people with whom she's speaking. In the beginning, she has a flat affect, especially during the intake in terms of facial expression. But as time progresses, her facial expressions become more animated and expressive. Same thing with her speech. In the beginning, especially the intake, her speech is somewhat muted and labored, and as treatment progresses, her speech becomes more intentional and louder. In terms of communication, she is able and willing to answer most questions from the staff. She often becomes tearful and upset when talking about herself and her struggles with her eating disorder. A few times throughout the documentary, she does become angry and aggressive towards staff, especially when they accuse her or confront her on things. She starts to curse a lot and speak loudly. So her presenting problems, there's an ongoing restriction of energy intake relative to requirements. She restricts what she eats. She is dealing with ongoing purging episodes via her feeding tube, which I'll get into specifically later. She's dealing with a debilitating fear of gaining weight. She has strained relationships with her mother, father, and she has a twin sister. She has history with substance misuse, and she has intense feelings of anger, sadness, anxiety, self-hatred, feelings of stupidity, and weakness, especially since being taken off the various medications she was on when she came in, including Klonopin. So course of development. A lot of this, the documentary doesn't get into specifically, so some of the information is a little vague or from secondary sources, but she began restrictive eating at a young age. This probably began around the time her parents divorced and Shelley moved to Salt Lake City with her mother. This is what her father mentions in a therapy session, and Shelley doesn't deny this. She seems to agree that the anorexia probably began around the time that she moved in with her mother in Utah. At some point, her father had a feeding tube placed in her stomach, obviously before she turned 18. And for the past 5 years, Shelley's eaten exclusively through that feeding tube. She began purging through the feeding tube. She mentions she can do this by flexing her stomach muscles and kind of just pushing out the stomach contents. Also, she states that she removes her stomach contents directly from the feeding tube using a syringe. Shelley has been hospitalized 10 times for her eating disorder, and in the past year she has spent her birthday, Christmas, and New Year's all in the hospital. Sorry, excuse me. So for past treatments, we know that she has been hospitalized 10 times, and at some point in the documentary, she mentions that she's been in treatment before, but we don't know how many times or the length of her stays that she was in treatment. Okay, relevant medical history. Shelley mentions that she's had 2 near suicide attempts, both of which she states that she didn't follow through because of how it would impact her family. But in one instance, she stole insulin from her work. I haven't mentioned this yet, but she's a psychiatric nurse. She stole insulin from her work at the hospital and nearly injected it with the intention of dying. And in the other instance, Shelley crushed up various pills that she either was prescribed or took, it's hard to tell which, and dumped them and intended to dump the pills down her feeding tube to overdose. She's a smoker. We don't know at what point she began smoking. And as I previously mentioned, she's been in the hospital 10 times for complications associated with her eating disorders. Okay, social and family history. She has very strained relationships with her mother, father, and sister. You get to see throughout the documentary interactions with all 3 of these people, 2 of which are in like a family therapy setting, and the other in kind of with her mother. She's just interacting with her mother in like a casual situation on the floor of the treatment center. As I mentioned, her parents divorced and moved away from each other, and Shelley initially went and lived with her mother after the divorce, but otherwise her living arrangements are unknown. So a big issue with Shelley is her twin sister and her relationship with her. Shelley compares herself to her twin sister, who she says that everyone just loves and admires, and she's sees her sister as, like just the greatest thing, and everyone treats her very well. And Shelley states that she sees herself as in competition with her twin sister and very much wants to stay thinner than her and to look better than her. And Shelley also mentions that she feels weak and stupid compared to her sister. And she mentions this in a family therapy session. And her and her sister have somewhat of a contentious back and forth in the therapy session, where Shelley explains, her perception of her sister and how she and her sister are treated differently by other people in their lives. And her sister talks about how harmful Shelley's behavior has been, and how it's very exhausting to worry to the extent that she does about her sister, and for it to have gone on as long as it has. Shelley also states that she mistreats and yells at her sister because when she does so, she feels like she's yelling at herself because they are identical twins and they very much look alike. Additionally, the father reports that the client has become addicted to various medications, and it's hard to pin down exactly how long and what, and it's hard to pin down the nature of Shelley's substance misuse. But when her father states this in therapy, Shelley doesn't seem to refute it in any way, and seems to kind of acknowledge, yes, I've had some issues with substances as well. Also, in this therapy session with her father, he talks a lot about how powerless he feels and how difficult it is because he knows he can't do anything to help his daughter and her eating disorder, and that powerlessness is very frustrating for him. And as I mentioned, she is a psychiatric nurse. Okay, so for diagnostic impressions, I would diagnose Shelley with anorexia nervosa with the specifier binge eating purging type in partial remission. The severity can't be determined because severity for anorexia is determined with the body mass index, and we don't know that. BMI is calculated using height, weight, age. We know Shelley's weight at various points throughout the documentary, and we actually know her age too, but we don't know her height. So it's impossible to determine exactly her BMI. Purging type was specified because Shelley admitted that she's been purging her resource drinks, and the resource drinks are like supplemental nutritional drinks that are like high in calories and protein that the residents are required to drink periodically. So Shelley meets criterion A, which is there's a restriction of energy intake relative to requirements leading to a significantly low body weight. In the film, Shelley's nutritionist explained to her that she weighs about 80% of what a healthy woman her age weighs. And this is stated after Shelley has gained some weight. So she was very thin when she arrived there. Criterion B is there is an intense fear of gaining weight or becoming fat and persistent behaviors that interfere with weight gain. So Shelley states that she fears that the staff at Renfrew are trying to make her fat. She says that they're feeding her too much. She asks her mom at one point if her mom thinks she's fat. Also, Shelley's seen hysterical and crying at a dinner table with some of the other residents because she's really like stressed out and panicking because she has to drink a resource drink. So that indicates, a serious, intense fear of gaining weight. For criterion C, there must be a disturbance in the way in which her body weight is experienced and undue influence of body weight on self-evaluation. So Shelley clearly meets disturbance in her own body image. Also, for criterion B, I forgot to mention, with the behaviors that interfere with weight gain, Shelley admits that she has been, at one point she admits she's been purging her resource drinks. So that's clearly a behavior that interferes with weight gain. So I diagnosed partial remission. This is diagnosed if the full criteria for anorexia were previously met. Criterion A has not been met for a sustained period, but either criteria B or C are still met. In this case, Shelley still meets criterion B and very much fears gaining weight. At Shelley's last weigh-in in the documentary, she weighs 103 pounds. So this is up nearly 20 pounds from her weight when she entered treatment, which was 84.3 pounds. So at this point, criterion A is likely not met. Though, like I said, we don't know the BMI, so it's difficult to determine exactly what her BMI is at this point, but it's very likely that 103.4 is not significantly low. So case conceptualization and treatment plan. Traditionally, anorexia is treated using a multidisciplinary approach that will address these three areas: nutritional support, psychological counseling, and behavior modification. So for the nutritional support piece, positive reinforcement should be utilized to praise weight gain, or in Shelley's case, weight maintenance. Obviously, it would probably be good for her to go past 103 pounds, but in the case that this is a healthy body weight, or at least on the lower end of what is considered normal, you would want to praise her weight maintenance. So meeting target weights should be linked to privileges, and the monitoring of food intake and weight is very important, but it's very important that this is not done in a punitive way, and it's done sympathetically by the nutritionist. For the counseling piece, a cognitive behavioral approach will be used with the emphasis on increasing the client's ability to recognize and change maladaptive thoughts and perceptions about food and about eating. Since Shelley's relationships with the majority of her family members are very damaged, psychodynamic therapy can be used to improve these relationships and improve her functioning in them. For behavior modification, this will be done utilizing body image directed interventions, and I'll talk a little bit more about these later. But some examples of these include exposure to avoided body-related situations, reducing the amount of checking behaviors, mirror exposure with a therapist there to give her positive reinforcement, and video confrontation, which is a detailed video recording of the client's body and confronting the client with this recording in therapy sessions. So body image is a really important piece of anorexia, and Schiller calls body image the picture of our body that we form in our mind, which is pretty straightforward. Most people consider body image as a construct made up of several parts, including attitudes, perceptions, affect, and cognitions about the shape, form, and size of one's body. So body image disturbances have been shown to be associated with anxiety and depression throughout treatment. Also, body image disturbances are reliable predictors of relapse. Therefore, the body image directed interventions will be a vital aspect to Shelley's treatment and recovery. Here are some screening tools. There is the National Eating Disorder Association screening tool, the SCOFF questionnaire, and the Eating Attitudes Test, EAT26. And the links to those are provided there. So for ethical and legal considerations, we want to make sure that the setting in which Shelley's seeking treatment has the appropriate professionals to implement this multidisciplinary treatment approach. Also, ethical guidelines mandate care that care that benefits the patient, advances self-determination, and avoids harm. However, an ethical dilemma arises when severely underweight patients refuse treatment. Eating disorders, specifically anorexia, are very dangerous and often lead to death. So it brings up the dilemma of what do you do when someone's on the brink of death and don't want to seek treatment. Involuntary treatment for patients with eating disorders is extremely controversial, and rigorous debate regarding the ethics of it continue. Involuntary treatment is authorized by civil commitment laws in all 50 states. So in some instances, involuntary commitment can save lives, but in some cases, this will break the therapeutic relationship and cause the patient to quit treatment altogether. So ultimately, it's up to the clinician's discretion, but this decision should be made with serious contemplation and perspective on the implications that the decision will have on the therapeutic relationship, on the immediate health of the client. For multicultural considerations, cultural norms across gender and racial demographics are discussed in this article. It states that anorexia is most common among white women from Western industrialized countries, which applies to Shelley. Western countries have been found to have higher levels of drive for thinness, and also Western societies have higher rates of body dissatisfaction. Also, the prevalence of anorexia appears comparatively low among Latinos, African Americans, and Asians in the United States, but it is important to note that mental health care service utilization among these groups varies substantially across cultural contexts. And here is my works cited. Thanks a lot.